tried to talk a little bit about looking ahead and what that looks like.
Thanks, Holly. And it's sort of wrapping it up with this last slide. As we noted that this is work in progress. There has been commendable advancements in the agenda, but there is some continued work that is underway. And here we note that there is currently an analysis to assess opportunities to align results-based financing with public financial management system, looking at this as a very critical step towards closing the cycle in terms of the institutionalization itself. There are other complementary activities, particularly in view of the advancements that the country has made. In this case, we're looking at the electronic health records that are being rolled out. The system is being rolled out nationally, and there are advanced discussions on assessing the feasibility of leveraging on this progress to use blockchain in the verification of RBF, that in itself actually facilitating greater cost savings. There is focus also on strengthening accountability through digital-based commodity tracking to the last mile to reinforce the governance perspectives. And then also there are ongoing capacity building of institutional and community governance structures, as well as skill strengthening in the use of data for decision making. Next slide, please. Which is basically our acknowledgement slide, just to acknowledge the government of Zimbabwe, in particular Ministry of Finance and Economic Development and the Ministry of Health and Childcare in the stewardship and also the financial support to the approach. We note the cities of Harare and Bulawayo, who have been piloting the urban voucher component, the implementing entities, Code Aid and Crown Agents, the Health Development Fund, the World Bank, and the Global Financing Facility for the funding and the technical support throughout this journey. Thank you.
Thank you very much. And for this presentation, which really sets the stone for everybody and for the next step of our meeting. So this was a great presentation, and I think this material will may be made available. But if anybody has a very important or burning question to ask, I will allow 1 or 2 questions before we move to the next speaker, who will be Sir Adley. So just if you have 1 or 2 questions, I'll be happy to take them on this presentation that has just been made. If you have any questions, just voice your question.
Okay. All right. So my name is Martina. I work for the WHO P4H. Thank you, Ching. Thank you to the 2 presenters for the wonderful presentation, giving us an introduction on the institutionalization of results-based financing in Zimbabwe. So I was just curious on, I understand that there were some studies to analyze the cost effectiveness of the RBF before considering to institutionalize it. But I wanted to understand if there were some consideration to do a budget impact analysis, because as we all know that where resources are limited, a cost effectiveness analysis result can only inform so much. So in terms of sustainability and also a plan to ensure that this is sustainable over a long time, yeah. I wanted to understand if there has been a budget impact analysis to just make sure that resources are available, and once the government takes it over, it will be sustainable. Thank you.
Thank you very much, Martina. Question well taken. Let us see if there is another question. We'll be happy to take, and then we will turn to the presenter very quickly.
There's some questions on this. There are some questions on the chat.
Yes, please. What's the question? Can you read it to us?
One says, do you think the Zimbabwe RBF model is scalable to some other countries? If so, what might this require?
Okay, scalability, if I can put it that way.
Yeah.
of Zimbabwe model.
Yeah. The other one says, what were the major strategies you carried out to convince the government of Zimbabwe to invest in this initiative since starting?
Okay, what was the strategy to convince the government to invest? So,
Yeah.
colleagues who made the presentation, can you respond quickly to 3 questions? The first one from Martina from WHO, asking about budget impact analysis in terms of sustainability. Second question, how scalable is Zimbabwe model? And third, what strategy was used to convince the government to buy into result-based financing in Zimbabwe? Very quickly, in 2 minutes.
Thank you very much, and thank you for those questions. Just very quickly, that in the medium-term framework that was developed, there was effort to really look into the budgetary aspects and also just focusing in terms of resources, both from the domestic angle and as well as from external funding. So whilst not really noted as a budget impact analysis, there was a conscious effort to look at what options would be available in terms of the funding, given the envelope is a key aspect to this. The cost effectiveness analysis, on the other hand, was mainly linked to the impact evaluation, making use of the results of the impact evaluation and then looking at the costs that had gone into. So from both perspectives, there is some indication of what a mature program would ideally require to implement and possibly facilitate some return on the investment. In terms of scalability, I think the key aspect is really around making use of the existing systems and making sure that the approach can be adapted to in the particular context that it is being introduced. So it is not so much about having external vertical structures, but rather making sure that the functions or the principles of results-based financing are actually integrated within the existing systems. And that way, you can look at it from a financial sustainability perspective, as well as how not minimal disruption to the implementation or service delivery in general. So it is possible to scale and not picking it as it is, as one of the lessons that Holly mentioned, that it had to be adapted to the Zimbabwe context. For a convincing government, I think it's an important question again, because at first it was really a point of discussion, because government felt at that time that, well, we would need to understand what would be the value add. And we feel that the main aspect really is really about the demonstration of results, both from external, that is in other countries that have implemented, as well as looking at the flexibility in making sure that the approach can be adjusted to suit the existing systems that are in the country. And for government, I think they really took that on board and managed to actually have everyone rally behind the approach. Thank you. I think you're on mute, Gaston.
Gaston, you are muted.
Yeah, thank you very much. Before we move ahead, I would like to check if we still have the translation from English to French. Is it still available, so that we are sure that everybody is at ease? Can you confirm that it's going well? Est-ce que la traduction marche?
Nous entendons très bien.
Il marche très bien.
Ouais,
On entend très bien.
Merci beaucoup. OK, tant mieux. Donc, nous pouvons continuer. So, you have the choice in French or English, up to you. So now we'll move to the next commentator, who will be Sir Hadley. He's a research fellow at ODI, leading cutting-edge research on public finance management, including on the organizational capabilities of finance ministries and the role of financial management in service delivery. He has co-authored so many documents and books and papers with the World Bank as well. And we are really delighted to have him to comment on what has been going in Zimbabwe, particularly with respect to institutionalizing result-based financing. So, Sir, can you hear me? The floor is yours.
Very well, thanks, Gaston. Thanks for the very generous introduction. Just so that everyone's clear about where I'm coming from with this. So I don't know the context in Zimbabwe that well. I know a little bit about Zimbabwe, but certainly not that well. And everything that's been sort of just presented is, is kind of very promising and a very interesting kind of agenda. So, firstly, I think congratulations to the team that's been working there. I think you're kind of ahead of the curve in this area. My kind of specific interest in this topic has come from partly with working with bank colleagues on the question of mainstreaming results-based financing in national public financial management systems. So quite a narrow kind of part of the kind of broader picture. And my experience is very much influenced by the work of myself and my colleagues in Uganda, where this is being also kind of discussed as part of the government's reform agenda. And so what I thought I would do is perhaps kind of just give you some reflections on how I kind of see this, what's just been discussed in contrast and in comparison to what we have been working on in Uganda. And so I think essentially results-based financing involves three kind of big changes to the kind of existing systems for financing and financial management. So one is the kind of the ability to pay facilities with transfers that can be used flexibly to improve services. The other is obviously to link the payment to verified data on service delivery performance. And the third is I think where the kind of central government and local government step up their stewardship role, both in terms of the support that they provide to facilities to improve their performance, but also I think in terms of managing the overall incentive framework. And so mainstreaming essentially raises slightly different questions for each of those three kind of features of the RBF model. And I think it also then raises a kind of number of broader questions about the allocation of resources as well. And so that would include, for example, the affordability of the RBF model, particularly as a pilot, whether the health system, is adequately financed and staffed more generally, and how equitable kind of staffing allocations are. And I think the kind of third, kind of important one that's been demonstrated in quite a few countries is the kind of broader coherence between results-based financing and other systems for funding health services, both included, often including things like in-kind drug supplies and distribution systems, other intergovernmental fiscal transfers, insurance systems, and things like that. So I think that all of these issues kind of come up in the institutionalization question. I think, Chenjerai and Holly have kind of already kind of alluded to many of these. And in Uganda's was no exception. I think Uganda, the questions were raised in all of these areas. So for example, when the government sort of decided that it could potentially mainstream RBF from a project into the government systems, it decided that the results-based financing model as it was not affordable. So, one of the likelihoods is that the performance grant will be reduced, and it could be reduced by as much as 70% to local government. So this would be quite a significant change in the original model. Results-based payments might also be cut from hospitals. So that was kind of an important shift in the kind of design that was needed. In terms of kind of just making it affordable and kind of setting it up to be integrated into the government budget. Then in terms of that kind of first area of the kind of PFM system, in terms of kind of giving facilities financing and flexibility over their budgets, the government was actually very hesitant also to give facilities autonomy to use the grants that they receive to top up salaries and also to purchase drugs. And again, this was kind of a major feature of the results-based financing scheme, and it's partly because of the broader setup of the health financing structures and the use of one on the kind of drug side, the use of national medical stores, and on the personnel side, the control that's implemented through the Ministry of Public Service. But where most of the complexity came in Uganda was definitely around the ability to link performance-based payments to the to kind of institutionalize the performance-based and performance orientation in the system, and it was decided pretty early on in Uganda, where it was that the cost and complexity of linking the verification of services to quarterly releases was going to be too demanding on the national systems. And so the government has been considering whether to introduce like an annual or a semi-annual performance assessment instead. And these conversations are still ongoing. And you know, so that this is kind of a direction that it might go in rather than one that's definitely firmed up. And then the last kind of observation, which has been from the team that's been working in Uganda more generally, it's not necessarily linked to just results-based financing, but observation of other performance assessment systems, particularly for grant funding of local government infrastructure, suggests that the stewardship role is one that can be proved to be quite difficult to sustain in terms of quality and emphasis once the project has ended. So if you get, so we've got kind of a government-run performance assessment system and a World Bank-run performance assessment system, both for local governments, but they are working in quite different ways, partly due to how they've been institutionalized. Now that's just kind of Uganda. I think maybe just to kind of reflect briefly back on what kind of really struck me from the discussions and the kind of context in Zimbabwe. So I think one is that I think there are factors in Zimbabwe that will have helped simplify the mainstreaming process. I think the fact that Zimbabwe is a deconcentrated health system rather than a devolved health system like it is in Uganda and also in countries like Tanzania, I think that helps. I think it simplifies the challenges on integrating funding into the budget, into the release and the control systems. But perhaps there are some areas where Zimbabwe has faced or will face greater constraints. And I think it would be interesting to hear a bit more about this. And I think one is the challenges around giving facilities autonomy. So Uganda has been providing grants to facilities for over a decade. And as I understand it, that's not necessarily the case, or not always been the case in Zimbabwe, where the facility budgets have been managed at the district level, at least in non-RBF districts. And I suppose the kind of general lesson is that reform in its own right has been quite a complicated one, and you know, often quite a costly one. So it'd be interesting to hear a bit more about how that goes going forward. And I think the second is related to the provision of predictable payments to facilities. So so the budget in Uganda is relatively stable. Local government grants tend to be released in full. And so even then there are kind of small issues, but on the whole, it's a relatively kind of predictable system overall and a good foundation for providing RBF. But in Zimbabwe, you know, sort of inflation is very high. Cash rationing has been an important tool for the Ministry of Finance to support fiscal control. And I guess I would see this as a kind of particular risk around supporting predictable payments, and it'd be interesting to hear how those discussions have evolved with the government, and you know, what systems have been put in place, or what kind of plans have been put in place to help ensure that you know, that doesn't become a problem. So you know, just to kind of maybe kind of broadly reflect back, I think there's I think the kind of big questions around those specific issues. So and I think particularly around the volatility of or the unpredictability of cash payments and their value, and how that influences the kind of incentive system that's being introduced. I think that would be very interesting to hear something specific about. I think I would also be very interested to hear about how the kind of current discussions on the comparison between results-based financing and direct facility financing, which is perhaps that kind of first element, that kind of autonomy, the kind of autonomous grant, like sort of grant funding and greater autonomy over spending decisions. Seeing as these are kind of clearly related, like how is that, but the kind of evidence is emerging perhaps quite suggestively that direct facility financing is perhaps more cost effective. How is this evidence and this kind of debate shaping the discussions in Zimbabwe, if at all? And then the kind of last question I have is perhaps for the broader room, which is, you know, what can we learn from the Zimbabwe experience? What would you take away from the Zimbabwe experience that other countries should be, and other project teams should be thinking about to avoid some of these kind of complex transition questions, and perhaps do more around ensuring pilots are affordable, that the pilots that are set up do use or shadow country systems from the start, we kind of do this much better, I think, as a kind of international community. So much less necessary to do with just how things are in Zimbabwe, but how do we do this better as a community? So I'll stop there, but thanks very much, and I'm happy to elaborate on any of these points or the experiences in Uganda.
Thank you very much for your comments and the linkage you made with the situation in Uganda and the two broad questions that you put forward at the end for us all to reflect on. Thank you very much, Sid. So if Bruno is around, Bruno. So Bruno Medsen is an economist. He joined the Health System Governance and Financing Department at the World Health Organization in Geneva in 2020. And of course, before that, he has close to 20 years of long academic career. Many have met him through result-based financing because he was one of the leading person at the beginning of the result-based financing conceptualization, performance-based financing issues and concerns. And the first step where we try to organize things, he was the one who almost started the first experience in Rwanda and then organized it in a way that the reflection started building up, and then a lot of other institutions like the World Bank joined in. And until today, Bruno is still working with us. So happy to have you around, Bruno. Please, your comments considering the Zimbabwe experience.
Thanks, Gaston. And then I'm not in my office, and I just realized that the camera on the computer is not working. So I'm sorry for that. I may switch on later on. But okay, no, thanks a lot for being with you, for inviting me, and merci Gaston, merci à tous. I really enjoyed the presentation by Chenjerai and Holly, and they have made really important points. And I would like to come back on some of them. And share some general messages actually, and sorry, I was in academia before, and I wrote my PhD actually on new institutional economics applied to health system, and it's in this PhD I try to theorize a bit performance-based financing, and for that I had to reflect on what is an institution. Because PBF is obviously, you try to change institutional arrangements, you try to move from input-based funding to output-based funding, you give more autonomy, so it means you give more decision rights to health facilities, and so on. And actually, over the last 40 years, there have been fantastic developments in economics on how to look at institutions and organizations. So what is an institution? Take the traffic light, for instance. All of us, we know the traffic light, and it's an institution. It's an institution because it's a pattern of social behaviors to solve a coordination problem. So without traffic light, we would have a lot of accidents at the crossroads. And the traffic light, by being green for one road and red for the other, is of course, it's a technology, but fundamentally it's an institution, because when you reach a traffic light, you expect that others will respect the institution actually. So it's you will stop when it's red, you will move when it's green, and you expect the others to respect. And this is how the traffic will be very fluid. And all those who are involved in the interaction are aware of that's the right pattern of social behaviors. So what we try to do with these reforms is to change the institution. So we try to move to one point to another one. And we try that the new one is what economists call a Nash equilibrium. So no one has an interest to deviate. We are happy with the new arrangement, so we don't undermine it. We comply with it. So this is really important, because if you have a good an institutional arrangement which is superior to the other one, you will better solve the coordination problem. You remove uncertainty. At some stage, it can become a problem. It can become a trap, because you are stuck with an institutional arrangements. Maybe some people don't want to move to another one because they have interest there, and so it can be a trap also. So I think that we have been thinking, and that's the RBF movement as well. We have been thinking about that as something we could bring from outside. And I believe that now, if I look back after 20 years, there is a shift in the understanding. I believe that more and more of us believe that this discussion on institutional arrangements is really the equilibrium, the fact that we will not deviate and then we will sustain. So this is what we mean by institutionalization. It's a matter of national political economy. So it's really about national stakeholders believing that what they have now is good, and they will fight to keep it. So I think it's much less. I think that aid agencies, to some extent, must be less present in this discussion, and we really have to create space for citizens, governments, actors to really institutionalize the arrangement. So I think that it's that institutionalization is bringing things within the national political economy system. So we just heard about the importance of integrating into public finance management. Public finance management means, for instance, that the investment, the spending is checked by the parliament through the budget once a year. This is what we mean by institutionalization, I think. And if if they really see that your new scheme, if you bring a new policy as the World Bank, for instance, if it will be institutionalized to the extent that national stakeholders believe that it reach its core objectives, to improve health, to protect people from poverty, but also to the extent that it contribute to the social fabric. And that's maybe my second point, is that we have not been looking enough at how this kind of reform consolidate the national social fabric. And obviously it's relevant for any country, but we know that Zimbabwe has gone through political turmoils for a while, and now they are rebuilding the country, the nation. And so the question of institutionalization is, okay, how does it fit there? There was 2 years ago, there was a nice paper by Eleanor Beth-Weil and Jill Oliver, and they say health systems can offer a unifying national ideal and build social cohesion. It can influence and legitimize popular attitudes about rights and entitlement with regard to healthcare and inform citizens' understanding of state responsibilities. It can strengthen trust in the state and legitimize state authority. And it can communicate the extent to which the state values various population groups. And I was listening to Chenjerai, and I think this is what I think has been done quite well in Zimbabwe. For instance, a bit like Burundi, they merged the PBF scheme with the free healthcare policy. So at least the PBF is there to enforce the free healthcare policy. And with the free, the citizens, they do not see the PBF, the RBF. It's very technocratic. It's relationship between the government and the facilities, but they see the free healthcare. And so by consolidating the free healthcare, the citizens see what are the state responsibilities. It's universal health coverage. You strengthen the trust, and you value various population groups. If the free healthcare targets women, pregnant women, or children under 5, for instance, you show what you really value. So I believe that institutionalization is that actually. It's really how you fit the policy within the social fabric. And I believe that as external actors, we have not been paying attention to that enough over the last decades. And it's not surprising that those countries which have been quite successful to sustain the RBF reform, like Zimbabwe, so it's 2000. I read 2011, so that you have celebrated 10 years of PBF. That's institutionalization. It's there. It's the case of Burundi, and these countries have indeed find a way to make it really part of the social fabric, and with buy-in of the governments and the president, for instance. So I think we have been looking at these interventions, these programs, very much as schemes. And at WHO, we really recommend everyone to look at systems. So the health financing system, the health system, and just what I explained, the socio-economic, the society system. And so we have probably to reflect a bit more about how the things we have been trying to support fits into this system thinking. And my feeling is that probably, and that would be my advice, and I think this is what Zimbabwe has been doing. It has been using the RBF scheme approach and adapting it and always learning and innovating. But this has maybe not the case in every country, so it has created frustrations, which I think are really serious. And the idea would be, look at your intervention, and I'm not talking so much for Zimbabwe here, but a bit like we heard about Uganda. and try to look at what are the core mechanisms in an RBF program, and maybe be more selective, because the point is that you need to take the mechanisms which are so important for building the system. So it's important, of course, to reach outcomes, because it's the credibility of the policy itself. But you need also to pick maybe focus on the mechanisms which build the whole system. So the point there is that don't try to institutionalize an acronym. Don't try to institutionalize RBF. That's really not the goal. It's just a step. So it's about building a health financing system. And so if you have already a RBF program in the country you support, maybe it's time to assess and say, okay, there are some components we will not be able to scale because they are too costly, for instance, or they don't match so much the need of the country, or they are not politically acceptable, but they are really mechanisms that we value. And we heard that, for instance, we could decide that we believe that autonomy of health facilities was probably very important, and it's important that they have cash on their bank accounts. But there are other formula which can be used to bring this cash to the front line than the very sophisticated formula used by most PBF schemes, where you have the output, but you have also this long checklist which is expected to be checked every quarter. This is heavy, and that's maybe too costly. So I believe institutionalization is about thinking in terms of progressing with the system, and also maybe being able to look at the scheme and take the core mechanisms and be ready to drop some if it's relevant. So adaptability and learning is really key, and I believe that's part of I followed the chat of this excellent webinar, and I think that I noticed that both Shenjerai and Holly have stressed the importance of learning. And learning is indeed improving the things you do, but it's also about self-reflection about whether the approach is the right one and whether you need to adapt it. And that would be really my core recommendation. After this intervention, I will share in the chat a webinar we organized very recently on learning health systems for UHE, and you will get there some messages about how learning is so important for the sustainability of your health policies. Okay, Gaston, I will stop here and I will try to fix my camera now. Thanks.
Thank you very much, Bruno. We really appreciate your perspective, in which you remind us that, yeah, we have to look at the meaning of institution and look at the big picture of RBF in the context of health system. And you provided a kind of framework that will help us really to put things into perspectives. And this is really what is appreciated from you, the way that you look at things in a very organized way. So this is really helpful. So thank you very much, Bruno. And this was the two main commentators that we're expecting to listen to. And then from there, we'll open up for you, and you have been following for a while. So now the floor will be yours. So I will also ask Wally to keep track of the questions that are coming in the chat, because I'm not able to follow them, unfortunately, and to draw my attention so that we can also include those questions. So in practical terms, I think that we may take at least 3 first questions, and you are free to address your questions to whoever you want among those who have presented. And I remind you that we got presentation from Shenjerai and Holly. They made the initial introduction presentations. Then we had comment from Sierra Hadley, and very recently from Bruno Mensen. So the floor is yours for any question you have. Just say your name, your institution, and give your question and to whom you are addressing the question. If it's also comments, just let us know that this is your just comment that you are making, and make short your comments and make short your questions. So let us go for the first 3 questions, and then we'll open for the 3 next questions, and so on and so forth. And we have a bit of time to do that. So the floor is yours now for your questions. Please feel free. Maintenant, vous pouvez poser vos questions et c'est vraiment libre. Nous n'allons pas imposer de format. Si vous avez des questions, juste levez la voix et puis dites, j'ai une question, je suis un tel, et puis vous donnez votre institution et vous posez votre question directement ou aussi dire à qui vous la posez pour rendre ça plus facile. Nous allons prendre les 3 premières questions et puis ensuite, nous allons continuer ainsi de suite. Il y aura aussi des questions dans le chat. Vous allez essayer de les prendre aussi. À vous.
Allô?
Allô, yes?
Oui, merci Bruno et merci aussi à tous les présentateurs. Ma principale question est de savoir en termes d'institutionnalisation. Et pardonnez, je ne me suis pas présenté. Je suis Boris Bédiacan depuis la Côte d'Ivoire. Alors, je voulais savoir comment est-ce que le Zimbabwe a pu institutionnaliser les différentes fonctions de vérification et de contre-vérification tout en assurant l'indépendance qui est liée à cette fonction-là. Voilà, merci à vous.
Merci beaucoup. The question is, how was Zimbabwe able to institutionalize the different functions? Les fonctions comme quoi vous avez dit? Comme la vérification?
Oui, et la contre-vérification. Et quels sont les organes, les différents acteurs qui ont pris en charge cette fonction? Est-ce que ce sont les inspections, etc., etc.?
Okay, how was functions such as control, verification, institutionalized within in Zimbabwe? Did you use any specific organization like within the Ministry of Health, outside the Ministry of Health? How was it organized? That was the first question. D'autres questions? Any other question? This question is from Boris, Côte d'Ivoire.
Oh, yes. Can I ask, please?
Yes, please.
Okay,
just my name.
Yeah, my name is Mohamed Lamine Dramé. Greeting to all, to Bruno, former colleague. I'm based in Guinea, head of a consulting firm. I have 2 questions. One is the autonomy of health facilities. Autonomy health facilities is really key. But what was the constitution? What kind of autonomy? Managerial, budget management, technical activities, supervision, what? Could you explain, and how did you do that? That's my first question. The second question is what usually we see in RBF in many countries, activities not rewarded, usually preventive activities, etc. We see that those activities are usually neglected. But if I understood well, all these was were very well taken in account. How did could they the speakers explain that more for us to learn from their experience, please?
Mm-hmm. Okay, thank you very much for this question, Mr. Mohamed Lamine. Any third question or third person to ask questions? Before nous avons déjà 2 questions, enfin 2 groupes de questions, enfin 2 personnes qui ont posé.
Je suis Mamadou Namodi Traoré.
Namodi Traoré, oui.
Du Mali. Bonjour Gaston. Je suis l'ancien collègue de Yann van der Horst. Je ne sais pas si vous vous rappelez.
Oh oui, ok. Comment ça va?
Et vous-même?
Merci, merci bien.
Merci. Alors, voilà ma question. Je l'ai déjà posée par chat, mais ça n'a pas été répondu. Je veux savoir quelle est la part de chacun des acteurs dans le financement de l'État, des partenaires techniques et financiers, et aussi les ressources propres des formations sanitaires.
Okay. So, the question from our colleague from Mali is the following. How much was the contribution of different partners intervening into result-based financing, partners as well as the government in terms of financing? What proportion was it over time in the case of Zimbabwe? So on my side, respond as a case. We'll try to answer those questions first, and then we can open the second group of questions. So, question asked by Boris. Monsieur Boris de la Côte d'Ivoire a demandé effectivement comment se passait l'institutionnalisation au niveau de certaines des fonctions, telles que la vérification, telles que le contrôle, etc., au Zimbabwe. So, how was different functions such as verification, control, and what other functions were institutionalized in Zimbabwe context? How was it done?
Thanks, Gaston. If I could come in, and I'm also
Please.
glad that we have several colleagues that might also come in at some point from the Ministry of Health, Ministry of Finance, and the implementing entities. But very quickly to note that on the verification side, it was a process of mainstreaming some of these functions to the key cadres that are already within the health system structures. And of note, there is an internal verification that is typically done before the payment of subsidies. And that function used to be undertaken by results-based financing officers who would come from the implementing entities. So this would be external, but over time and through a very structured capacity building process, those functions were then taken up by the community, a community nurse who by mandate was already supposed to be actually providing the supervisory aspects and also inspectory aspects in that regard. So those functions were basically taken up in terms of the internal or first levels of verification. But the external verification was also being done by an external entity, that is the University of Zimbabwe, again, within the context of the separation of functions. But noting that within the system, there is also the Health Professions Authority, which is also mandated to be assessing and inspecting on quality aspects for all the institutions and how the systems are being run. So over time, there was capacity building again and this is still ongoing, to make sure that the counter verification functions are taken up by the Health Professions Authority. So it has been a question of really identifying entities or structures within the system that could take up those functions, but still respecting the principle of separation of functions. Over.
A very quick follow-up question for you. When you say Health Professional Authority, what is it exactly? Because this is a concept that is not necessarily well known in the Francophone part of the Africa. So what kind of institution is it? Is it a government institution, or is it an independent institution related to the health professionals, separate from the government, or what kind of institution is it?
I would get some guidance further, but it is a collective of the professional authorities, and it is recognized as a government entity, although it has a specific mandate to provide that oversight in terms of service delivery. But I'm happy to have also some adjustments. I know my colleagues are also in line who might provide further guidance. But they have taken up, we've got different professional authorities that are part of this collective, and the training actually included the bringing together representatives from these to actually take up the functions for the verification. Thank you.
Mm-hmm. Okay, thank you. So,
sorry, if I get, if I get very well, for the external verification is made by the University of Zimbabwe, right?
Yes, and then they have shifted to internal institutions.
Okay, thank you very much.
Later. Mm-hmm. So, la question suivante de Monsieur Mohamed Lamine. The question is, what kind of autonomy you have? The question was in English. Quel genre d'autonomie est-ce que les fonds sanitaires ont? Est-ce que c'est autonomie d'un point de vue des finances, d'un point de vue technique? Enfin, quel genre d'autonomie était donné? What kind of autonomy did the health facilities enjoy from your experience? That's one. And the second part is, with respect to activities that are not rewarded, and it seems that in the case of Zimbabwe, those activities didn't suffer really in terms of not being taken care of. So what was the strategy? How did you do to make sure that those activities were still delivered as expected by the health professionals? So there are two questions here. Back to you.
Thanks, Gaston, and thanks for the questions. So on the autonomy side, I think we've made reference at times to what is being referred to in courts as guided autonomy, in the sense that there is a recognition that facilities would need to prioritize their facility investments. So using the facilities, and when I'm saying facilities, it is the health workers together with the community representatives at the clinic level. There is the health center committee. They actually sit together and actually prioritize what they would need to focus on in terms of investments. And based on this, they would actually have a plan to utilize the earnings that they would have obtained. And but this is done with support from the district level. Because that's where you also have the structures in terms of the public financial management structures, as well as the procurement related obligations would probably be at the district level, but the facilities would have identified what they would want to prioritize. So it is looked at from that perspective. There are other elements that you might want to reflect on in terms of RBF in other contexts where there's hiring and firing. In the context of that is the hiring and firing of health workers or staff. In the context of Zimbabwe, this is one particular example where the discussions with the government were very clear that we would want to see that autonomy, but not necessarily for certain elements such as the hiring and firing, because it may end up having some distortions in terms of the service delivery and the planning that would be conducted. So there are some adjustments. It has been adapted to suit the context and the preferences that are there within the system. And then for the incentive, the other indicators that are not incentivized, I think you summarized it well, Gaston, that indeed there wasn't any neglect of those indicators based on the impact evaluation results. But even in follow-up in terms of process evaluations, one of the key aspects was that the feedback from health workers was that from their earnings, as they look at investing at the facility, it goes beyond just supporting the areas that are for the for those that are incentivized. Some of the investments look at even the infrastructural aspects that would actually benefit everyone who would want to come and utilize a clinic, for example. So the main feedback that was coming through is that some of the benefits that will come from the earnings that they get go beyond those incentivized indicators. At times, they even buy medications for some chronic conditions that might not necessarily be in the package of the maternal, newborn, and child health indicator. So that's one of the reasons why you would find that there is minimal effect or neglect in terms of the unincentivized indicators. Thank you.
Thank you. So the last question was from Mamadou Traoré, who was asking quelle est la part de contribution des différents acteurs au result-based financing, notamment à son financement? How was the contribution of different partners, including the government, in terms of financing the result-based financing approach?
Thank you. So over the years, starting from 2013, the government has been contributing funding support to results-based financing. And in 2013, it was an initial counterpart financing of 1 million. And progressively over the years, it would come to about 7 million. And currently with the grant support from the Global Financing Facility, the government has contributed 24.6 million to counterpart finance the 25 million that is coming from the Global Financing Facility. That said, typically the pricing that is done in Zimbabwe is based on an assumption of an annual budget of around $16 to $18 million. So we have seen the increased allocation towards the support that's coming from development partners. And as mentioned in the presentation, since 2018, the government is now providing financial support to the 18 front-runner districts in terms of the subsidy payments and some of the operational payments, but with the aspiration that they would scale this up. But in relation to that, there's obviously an earlier comment that was mentioned around the need to further reflect on the predictability of funding, the timeliness of funding, and I think it is all part of the discussions around sustainability and the institutionalization agenda. Over and out.
Thank you very much. So, nous allons ouvrir la seconde vague de questions. So, the next series of questions, unless, Wole, do you have questions in the chat that we need to address?
Gaston, I think we should just continue taking these oral questions. Maybe after this round, we'll go to the chat and take some questions. Bruno also want to intervene at a point. And Gaston, to save time, we have translation. So please don't translate. Let's just go on as it is.
Great.
I know you speak the two languages, but don't worry.
Next question. Okay, next question.
Eileen?
Oh, sorry, you're referring. Oh, sorry, we're in a room. I need to mute. Sorry, we're in a joint room with computers. Can you hear me?
Yes, we can hear you. Go ahead.
Okay. Oh, thank you. Now I need to look here. Yeah, okay. I wanted to thank you so much. I think this is a super interesting discussion. I just wanted to ask a bit. I feel like we very often talk about institutionalization of PBF as the program, right? Try to think about how we institutionalize all the different aspects of the program as it was initially supported, while perhaps not enough focusing on which one should we actually institutionalize, which one do we really need, and which one are really too much project specific. So I was wondering, and I think that's why quite some other countries, like I think Tanzania or Nigeria, for example, have decided to let go of the fee-for-service mechanism to a large extent and move more to sort of transferring operational budget to facilities and having much less of the fee-for-service component so that they don't require that much verification as they did in the initial project. So that would change the question on how did you institutionalize verification and counter verification into sort of how did you diminish it and how did you institutionalize only what you think is really needed. So I was wondering whether the Zimbabwe team could reflect a bit on thinking about initially how the project looked like, what are the real key ingredients of the model that they think are really important for the institutionalization and which parts perhaps could be relaxed. Thank you. Over.
Thank you very much. That's one question, clear question. Any other question? We'll take three of them before we go to the presenter. Yeah, please go ahead.
Thanks, Wale, for getting me next. So Lombe Kasonde, I'm a health specialist based in Brazzaville, Congo. Thanks very much for the presentations. They were really interesting and very helpful. I just have a question going back. If you go back a bit, Chenjerai and colleagues, what were the sort of discussions or trade-offs you made before you set on PBF? And maybe if this dialogue evolved during the course of implementation, what other health financing mechanisms have been put in place or are being considered by government? Specifically, I'm interested in finding out if Zimbabwe is also looking at a health insurance scheme, if one exists already, or if there are discussions in that direction, and how PBF and health insurance would coexist if that is indeed the case. Over.
Thank you very much, Lombe. Third question, ask question.
Mohamed Vadel, your hand is still up.
Yes.
Do you still want to ask a question? Okay.
Mohamed,
yes,
go ahead.
Thank you so much. Just I would like to have an idea about the context in Zimbabwe regarding the payment method. Did they use the input budget or they use the budget program? Just for the context. Other questions are already answered by because they all posed by another participant. Thank you so much.
Okay, so let us go quickly to the presenter and not just limited to them, but whoever is in the group and would like to add any contribution is more than welcome. So the first question by Ellen is, okay, not everything or maybe not everything is to be institutionalized within Zimbabwe financing. So in the context of Zimbabwe, what was really felt that being important to be institutionalized and what was not really important to be institutionalized in this context or in your context? Okay, your experience, how was it in Zimbabwe? And maybe also, like she was saying, in Nigeria, it's not everything that was pushed to be institutionalized. How is it going in Zimbabwe?
Thank you. And a very important comment and question from Ellen there. So in Zimbabwe, my observation really is that whilst the design or the model itself has really maintained its original structure, there have been some adjustments that have been focused on more of mainstreaming those functions within the existing system that is there in the country. So it has not been so much around pulling out any component of the original design, but rather making sure that the processes or any elements of the model actually are seamlessly being integrated, and it's still work in progress. In particular, I think the verification arrangements is an example where you would find that there is that acknowledgement of the need to go to an approach that is not so intense and that is lighter. And the effort to now come to this risk-based verification whilst also mainstreaming the roles and functions to existing cadres is one example where that has been lightened. But at the same time, going forward, there's still this discussion around whether there would need to be extensive verification even when the country has progressed so much with regards to electronic health records. So again, it's really more of trying to make sure that you leverage on the progress that is being made within the sector and the systems, and then making sure that it is the principles and the functions that are taken into account, not necessarily as one mentioned, that it is not so much around the naming of it, but rather making sure that the principles and functions are incorporated. And it is interesting because this is really the core part of the work that's currently underway in terms of looking at the alignment of results-based financing and the public financial management system. And again, there has been extensive discussions in the past week focusing on what it is that we need to be looking at within RBF and what principle would need to actually be incorporated within the PFMS system and the other way around, such that those principles are taken forward in a way then they'll be fully mainstreamed within the way the government systems are operating. So I think that's what I can say for now, but maybe others could come in with specific examples on that point. Thank you.
Okay. I have the privilege of managing, so I think that the LL question is really a very important and interesting one, because if you look at the issue of verification, for example, for instance, do we really need to embed verification in the way that we have done it in result-based financing within the national system, things like that? So the question is broader, and maybe others can also come in on how do you really think of result-based financing in terms of institutionalizing? Is it getting the system that you have built into, or finding from the system that you have what are the best elements, the most promising one that you can infuse into the national system to take into consideration what Bruno was saying, that you look at the system, you look at the entire and not just to your model that you are trying to. So this is the kind of question that is really important, because many countries are struggling with those issues. What do you pick from there to move ahead? And it's related also to what Lombe was asking. So what are the mechanisms, finance mechanisms are considered by the country? Because we see, okay, result-based financing is one way of doing it, but are there other mechanisms that the country is considering in the context of Zimbabwe? Back to you.
Gaston, yes, I would like to take this, and because it's an important question, and actually I would like at the same time to answer to a question put by a colleague, Mamadou Diane Diallo, asking what is the link between PBF and the civil registration system. And it's a major one, actually. It's a missing link. If you must know that in high-income countries, hospitals are not paid the same amount, whether they do an appendicectomy or delivery. So hospitals will receive different payment from the Social Security according. It's the output-based payment. It's called DRG, but it's the same logic. So the purchasers practice different fees according to the activities. So this is possible in our country without verification and counter verification, because we have a civil registration system. Exactly. So each of us, we have there is a unique identifier for each of us as a citizen. And so when we go to the hospital, we give our ID, they take the number of the Social Security. And the purchaser has all this data about my use of services. They know, and they will notice if I got 3 times appendicectomy, they will know that there is something wrong there. And they maybe, if it's the same hospital, then they will suspect a fraud, because we have also frauds in high-income countries with health insurance and so on. So what we have and what we miss in many low-income countries is this civil registration system. And it's because we missed that we had to set up verification and counter verification. And so I would like to come back to the point I made. It's important that we take this kind of program that you do at the bank, and which are really important contribution. How can they contribute also to the system and to the public system? So if we run as Ellen said, if we just take the project perspective, we will think, oh, how can I institutionalize verification and counter verification? But if you take the system perspective, and I don't mean just the health system perspective, I take really the society system, we will say, no, we miss something. We miss this unique identifier for each citizen, and we, the health sector, we will go to the Ministry of Civil Affairs, the Ministry of Interior, and we will put pressure for them to progress on this kind of need, because it's up to them to set it up, but we need it for the health sector because we are moving to new kind of provider payment and we are moving to new kind of reform. So this is what I mean by taking the system perspective, and I fully agree with Ellen. We need to take the function perspective plus system perspective. We will identify new needs, and I think we have a responsibility to organize a dialogue and say, look, we believe it's time for your country to sophisticate a bit the public finance system and so on, and there is a cross-sector agenda. So yes, let's not be stuck with the things we have set up. Let's focus on function. And indeed, of course, you cannot set up a civil registration system in one day. And so this is also why I like the innovation brought by Zimbabwe. They have looked how they could do risk-based verification, which is something which is very relevant. And there, I come back to my point about institutions. The problem is that when you set up institutions, you create stakes. You have parties with stakes now, and maybe we have created a kind of bureaucracy of verification in some country. And these people, of course, they will fight for securing a very intense and systematic and verification. And I think it's up to actors like the bank to say, no, we want to move to something which is lighter, which is more cost effective. And guys, yes, we will introduce risk-based verification. We will not have exhaustive verification anymore. We will do sampling. And this is the way to go because we want to reform things. So let's not be stuck with the project that has been set up. Let's be innovative. And this is really, I think, the most important lesson from Zimbabwe. They have been innovating, learning and innovating. I think that's really key for institutionalization of this kind of functions, mechanisms. Thank you.
Thank you, Bruno. And this also linked to the next question that I was mentioning from Lombe, which is what are the kind of financial mechanisms the government is considering in terms of the health sector to move things ahead? Was there any scheme, insurance scheme or things like that beside of result-based financing that you mentioned? So to the team, and how are they related?
Thank you, Gaston. Yes, so the National Health Financing Strategy actually indicates the direction that the government wants to take with regards to a health insurance scheme. So it does outline the need to move towards a mandatory prepayment mechanism within the strategy. And there have been some discussions by the ministry around developing, in fact, it is now available, a roadmap towards a national health insurance. There is, however, some recognition that in between, as part of this roadmap, there are several other processes that might come in to address issues to do with efficiencies and effectiveness, and in particular around strategic purchasing. So you would find that the results-based financing is situated within the context of strengthening options for strategic purchasing at a national level. But the aspiration is that there has to be some convergence at some point towards a mandatory prepaid mechanism. There are still ongoing discussions on how that can be set up, and obviously a lot of technical work will need to go into that. But generally, that is the direction that has been outlined within the country. And so I think this relates as well to the commentary that has been provided by Bruno and Ellen in the sense that we need to be probably having that focus or conscious direction towards making sure that we are mainstreaming the functions or the elements of results-based financing within the system approach. And this would probably align very well with the direction that is much broader that is already being considered by the government. But it is it's a stepwise process, and it is really going to be looking at making sure that we sustain the current implementation modalities, while at the same time really rethinking how this could be refined to make sure that they gradually shift towards a systems approach. Thank you.
And also related to the issue of financing is the question from Mohammed Vadel, who was asking what method of payment was used in, I think in reserve financing, was it input based or budget program, or your question was related to the government system? I didn't get it quite fully. Maybe the presenter has understood the question.
Well, I could try. I think there was a reference to whether there is, where RBF fits within the program-based budgeting, whether the country is making use of that approach. And I hope I've interpreted it well. So just to indicate that there have been some advancements with regards to the program-based budgeting reforms within the country. But as part of the discussions on mainstreaming RBF and PFMS, the teams, basically Minister of Finance, Minister of Health, and stakeholders are currently reflecting on what it means when it comes to the results-based financing, how it is situated, and how this would align to this very important reform that's already taking place and that has progressed in the country. So I think what I can say for now is that yes, the country has actually moved towards program-based budgeting, and the Health Ministry was actually one of the pilot ministries at the time of introduction of this reform. Thank you.
Okay, good. Those were the three questions that we had. Let us, maybe I can go back to Wole. Do I continue, or you have some questions in the chat for us?
No, there are no questions. All questions on the chat have either been presented to plenary and be answered. And we also want to thank those who have been providing resources. Bruno said, Alison have been answering some of the questions and providing, other materials for people to look into. But I want to say something, Gaston, on the question that you asked with regards to how do we institutionalize. I think essentially what I've seen in some countries is the fact that, when we are at project stage, we should be very opportunistic, looking at what areas, what systems are currently within the country where we work, and how can we tailor our program, adapt our program to that particular situation. I will come with a few examples. I think when you talk about verification and you look at the function of the auditor generals, in most of our countries, I think that will fall within the purview of what they normally do as part of their service in government, auditing and looking at records, financial management, and issues like that. Another area where we could be opportunistic is looking at what are the current government policies. For us in Nigeria, I was holding back in giving that example. But for us in Nigeria, when we look at PAC under one roof, that allows us to be able to look at PAC at different levels, at state, at local government, and at the facility level. That provided window for us to be able to introduce the issue of autonomy, at the facility level, governed by the district, but funds directly go, to the facilities, which has been part of what Ellen was referring to, the DFF, that the Nigerian government has said this is what we are going to do, and they've now scaled it up to a national level. The window was there to do that, and it became how RBF, or whatever you want to call it, was institutionalized, in Nigeria. The other way to look at it is also there are some things that are not done in government before, but the project has brought it in. And you can look at that and look at also how, you can introduce this. I like what Bruno said about the social fabric. What the people see at the end of the day is the health services that they get. How it gets to them is not their major concern, but having good quality of service, and that does not impoverish them is what the people want to see. So we can work together with government on looking at what is in the government system and what we are bringing in, and find a middle road between the two to be able to make sure that we deliver services, to the people. That's just the point I want to raise on the question that you asked, Gaston.
Okay, thank you very much for your contribution. Much appreciated. So we will have another round, very short. Now we'll have 2 to 3, maximum 3 years, usually 3 questions. And after that, we will go for the closure of the session. So if you still have questions to ask or comments to make, please feel free. The floor is yours. Okay.
So
Yes?
This is Jean. Yeah, this is Jean. I think there is one question coming from Nam from Cameroon. Would like Chenjerai to elaborate more on the payment system. So if they can share the experience, how the payment is made and how it can be done on timely manner. I think it's a question from Cameroon.
Okay.
Yeah.
Can you explain how the payment system is or was, or it was and is in Zimbabwe, just to give a little bit of insight to our friends in Cameroon and also elsewhere?
Thank you very much for that. I will try, but I know I've got a very strong backstopping here on those who have been very close to the implementation aspects as well. So in terms of the payment system, I think maybe it would start off at a time when for the 18 districts, this was being facilitated through the implementing entity, that is CodeAid. What would happen is after the verifications have been done, an invoice is then generated to then specify what amount would be expected for each particular facility. Now, the clinics, that is those at the lower level, have a designated account, which is basically one in which they could actually access the funds, but after procedural aspects such as signatures by the health center committee and by a member of staff at the clinic, and also undersigned at the district level. So what would happen is that the payments are then channeled to the account for the clinics, or if it's a hospital, and then they would actually undertake the procedures for accessing those funds, including the indications around the operational plans that they have, and also taking into account the regulations as per the Procurement Regulatory Authority of Zimbabwe. So these payments would actually be coming through from CodeAid. And at the time when these were actually directly coming from the implementing entity, similar again from Crown agents, which would be catering for the 42 districts. But for the 18 districts, the counterpart funding from government would also go to CodeAid to contribute to the payments or the other operational costs. Now, if we look at the current situation for the 18 front-runner districts, where we now have the program coordination unit, the funds are actually coming from Treasury and coming to the Ministry of Health and Childcare, to the program coordination unit, and from there, the payments are then made directly to the facility accounts. Again, the functions or the processes of invoicing would have been done based on the verified data. And an added value that has come through is that this invoicing mechanism has now been integrated in the digital platform for the results-based financing, which is also integrated with the district health information system. So that smoothens the process. But just to note that for the 18 front-runner districts, the payments, because they have to be using the local currency, the invoices is generated and then sent to Treasury, and then there would be a disbursement based on the exchange rate, which would then facilitate for onward transfer to the clinics. I hope this addresses the question. And I'm just relating to Thomas' question that is asking on the purchasing agent, that for the 18 districts, the purchasing agent in this case is the program coordination unit, which is within the Ministry of Health and Childcare. So it is a unit that is having a specific mandate of actually managing specific grants. It is also mandated to also manage the Global Fund grants. But there is a team that's specifically looking at results-based financing. Yeah, thank you.
Thank you very much. I would like to give the chance to the other presenters and those who have spoken to intervene one more time if they want to do so. And I would like to go very quickly to Holly Baxter, if you have anything to say, and then I'll go to Hadley, quickly, and then finish with Bruno for your last words before we go to closure. So to you, Masters.
First, thank you for everyone for coming out and sharing your experiences and also sharing your questions here. We very much appreciate it. This has been a really good experience for us, and we've learned a lot about not only what's happening in Zimbabwe, but from a knowledge and learning standpoint, how to capture knowledge a little bit better. And that's been an exciting thing as we move forward. So I also want to thank our discussants here and Shanjarai for the great job that they've done with this. So thank you all very much. I'm gonna go ahead and pass it over.
Thank you very much. Really appreciate, and we have appreciated what you have presented to us, particularly focusing on what has happened in terms of the process and what were the key points you go through, explain to us the different important aspects and all the learning process through the issue of funding, of training, adaptation, ownership, communication, leadership support, pilot testing, donor support. So really, we really appreciate. So do you have any comments to make before we move to the two commentators? Shanjarai?
Thank you. Just echoing the very same sentiments. Just really appreciating the discussion and the questions, the conversation we've had, and also a lot of learning with the commentaries that have been provided. So really appreciating that. Thank you.
And we thank you very much for taking the time to organize this presentation. It was a really nice presentation. It provides really all the background with nice graphics. So we really appreciate it. Thank you so much for that. So now let me turn to Adley. Adley, last comment from your side, please.
So, I mean, again, I think I'll just like echo, I think that you should have more of these. I think this is great, right? I think the kind of team in Uganda would have benefited a lot from hearing these experiences. I think, you know, the kind of group that I work with, I'm sure that's also the case in other countries like Tanzania, where there's also big questions about the future of RBF. I think it's also very good to see quite a range of, you know, views and perspectives, right? Both kind of pragmatic, you know, this is the kind of route that we're on, this is how we adapt and iterate around an idea and a solution, you know, with a clear goal in mind, versus I think also some kind of, you know, healthy tensions around, you know, which aspects of RBF are kind of the ones that really people should be kind of focusing on as kind of critical mechanisms for delivering outcomes. I think what are the kind of broader tests we want to be giving to kind of questions around cost effectiveness. And I think those might not all be relevant right now in Zimbabwe because the path is set, but I think that healthy skepticism is really good for the kind of quality of the discussion around institutionalization. And I think the kind of maybe the last point I'll make is is on this kind of institutionalization point. I think for me, I think that the kind of big question is, how do you move from thinking about this as a project to thinking about this as kind of the day-to-day routines of government and the kind of stewardship role that the kind of center of government and local governments are playing. You know, I think if that moves, I think that's a kind of very significant kind of change in the way that health systems kind of are managed. I think you're going to get much more kind of fruitful results from that. I think kind of that's been made in many different ways, but that kind of iterative learning process and kind of forward thinking, like that's a kind of, you know, that's a kind of milestone in its own right. But like that's a, you know, that's the kind of long game. But no, thanks so much for having me, and you know, really looking forward to kind of hearing more of this and also more from the Zimbabwe team in future.
Thank you very much for your reflections. I very well appreciate it, and you had good points that we have really appreciated. So let me now go to Bruno. Bruno, your last comments.
Thanks, Gaston. And maybe I will surprise some, but I think that we have talked about it was great. It was really a great session, and it's fascinating to hear what Zimbabwe has done. But the lesson from Zimbabwe is not, I think, to replicate the PBF of Zimbabwe somewhere else. We have to move away from this way of thinking. I think what we have to replicate is the spirit of the stakeholders of Zimbabwe. They have been discussing this policy. They have been resisting to some extent. But they have developed ownership and really commitment. So it's their policy. So the question is not for us to say, Zimbabwe should do things in a different way. I think no way. Go on with your innovation. For me, myself, I'm certainly interested to see how you will harness electronic medical record and use it in your policy. So that's really interesting. Go on with this kind of innovation. We will learn from them, but also to other countries. Yes, how can you bring this commitment to learning, to studying, to this redesigning, innovating, changing things which are when they are not working, and always improving your policies. So really feel really free to adapt, to innovate, and don't feel stuck by one doctrine. This is, I would say, the main message. But build the system, build the health financing system, build the broader public system, build the society, consolidate your society. That's the most important. And this is what you will institutionalize, and this is really the future. So thanks a lot for this session, to GFF colleague for setting it up. It was really a nice learning activity. Thank you.
Thank you very much, Bruno, for reminding us always to, yes, act on RBF, but think about the health system. Thank you so much. We'll keep it in mind. So now let me finish by saying...
Gaston, let me just say one word before you close.
Sorry?
Wally, let me say one word before you close.
Oh yeah, please. I was coming to you exactly because...
Okay, sorry, I jumped the gun.
Yeah, I was going to say that we have a bunch of people who have helped us to put all this together. In particular, we have Joy Jebre, we have Wole, affectionately called Wole, and we have all the GFF colleagues who have been working behind the scene to make sure that we have this session. And of course, putting this forward, they may have also some comments, and we would like to open up for them to have a few words before we close. And that's why I was calling on you, Wole, to come in.
Thank you so much, Gaston. I think we want to thank you especially for chairing this event. I know the moment I told you, you accepted immediately, although we had to work around dates and things like that. We are really very grateful from GFF, the RBF coordinating unit from GFF. We are really very grateful. Bruno, always thank you very much. Thanks, Sied, thanks, Chanjarai, and our own Oli Basta. I just wanted to say that this is just the first in the series. Many of us are aware that at the bank, we look at impact evaluation, we look at cost effectiveness studies, on RBF, we get a lot of results from them. But there are some quantitative and qualitative, information and data that we can still gather, on RBF implementation. So at the GFF, we have about 5 or 6, case studies ongoing. This is just the first among them. We might be calling you very soon to look at RBF and supply chain. What innovation, what differences did RBF bring to supply of drugs and commodities, at the facility level. We are also looking at RBF and quality of data, that we have from med services. Verification has really helped. It's costly, but that's really helped us, to be able to get, quality data, and how has that process affected the HMI systems, of the countries where we have, where we've implemented RBF. In particular on the supply chain, we are doing, cross-country comparison. We are looking at Tanzania, Nigeria, and Liberia that have used different methods, through RBF to address the issue of supply chain management. We will also be looking at Cameroon, and there is also one on DRC. So we might be calling on you very soon for, seminars and webinars like this to pass on the information that we have gathered from this particular studies. Once again, I want to thank everybody for being here this morning on behalf of the team, and I look forward to, engaging with you some other time. Gaston, de vous remercie.
Thank you, Wole. Thank you so much. So I would like, again, once more to say thank you to everybody who attended this session. I will not pretend to summarize because there have been so many comments and summaries that have been done, so I don't need to come back. Just to say that this is the kind of things we'll be doing more, because it's needed for us to exchange and to have the bright ideas that are coming from so many actors working together and putting things together and reflecting on those things. And this is also an invite to everybody who is working on specific aspects in different countries to try to think out how we can share and learn from each other. Zimbabwe is a great example. We have a previous discussion on Nigeria, like Wole was saying, and we expect to get more from the other countries. So get us in touch with our friends from GFF, from the World Bank Office, WHO, etc., and encourage people to get into this kind of organization of networking, so that we can share lessons, we can learn from each other. And this is really great, because what has been happening in Zimbabwe is now being seen, discussed with the other countries. And I'm sure that it will be beneficial to all of us who have been attending this session. So thank you very much. I hope you enjoyed the session. And I hope also that the material can be shared one way or another. Maybe my colleagues from GFF will take care of this. But from my side, thanks to everybody, presenters, participants, and the organizing committee. Bye-bye, and see you next time. Bye. A real pleasure. Bye-bye.
Thank you. Bye.
Au revoir. Et à la prochaine.
Thank you. Bye-bye.
Merci
À la
beaucoup.
prochaine. À la prochaine.
Bye-bye. Merci.
Au revoir. Merci.
Au revoir.
Au revoir.
Merci.
Au revoir.
Merci.